And welcome back to our judges.
Judges, welcome back. If you want to introduce yourselves, it's probably easier to go in the same order that you went last time.
So can you hear me? This is Kim King. Okay, good. So good afternoon. Welcome everyone. It's a pleasure to kind of meet you, and we look forward to your presentation. My name's Kim King. I'm the president of Strategy Advantage. We're headquartered here in Los Angeles. We do work in major hospitals and health systems across the country. I started my career, the first 10 years at Cedars-Sinai, was an executive there, and then started the company in 2002. And we specialize in growth strategies of all kinds, whether it's enterprise strategy, program and or service line strategy, and therefore this is a really great case study from my vantage point. So good luck, and it's nice to meet you all.
Hi, good afternoon. My name is Victor Carrasco. I'm the CEO for East Los Angeles Doctors Hospital. We're a safety net hospital in East Los Angeles. And also our system has capitated lives. So this case study is relevant to what we do every single day. And I'm excited to hear your thoughts and your strategy. And I wish you good luck. Thank you.
And good afternoon, everyone. Demetrius Alexio here. I'm President and CEO with the Hospital Association of San Diego and Imperial Counties, and always look forward to the teams and the work that you do. So really looking forward to hearing your analysis and your thoughts. Good luck today.
Hey everybody, it's Mark Leeson, I'm the Chief Executive Officer of Tenet Health Central Coast. We are a 2-hospital market here in beautiful San Luis Obispo County. So very excited about College Bowl. I used to be a Cal president, and we've come a long way. So good luck today. We're excited to hear what you have to say and your conclusions.
Good afternoon, everyone. This is Evan King with Copel Solutions, the principal at the firm based in Los Angeles. I'm excited to see you all present today. I hope it was fun. This is actually our case, as well as the engagement I worked on a few years back. So excited to hear your thoughts. I know it's a challenging one, so hope you enjoyed it and had fun with it, and appreciate your taking the time with us today. Thank you.
Okay, hey guys, can you hear me? I'm Bonnie, Pamela C. I'm the Chief Operating Officer at St. Mary Medical Center in Long Beach, California. Part of Dignity Health, now Common Spirit Health. And looking forward to hearing your presentations today. And you know, when I look back at my days as a grad student, out in the East Coast, we didn't have anything like this. So I think this is awesome that you guys are having the opportunity to do this. So thank you.
Okay, thank you, judges. I'm going to turn it over to Resolve Consulting. Resolve, if you want to go ahead and introduce yourselves, and then you can start your presentation.
Hi, everyone. I'm Yaz, and I'm from Resolve Consulting.
Hi, everyone. I'm Helen. I'm with Resolve Consulting.
Hi, everyone. My name is Madeline. I'm also part of the Resolve Consulting.
Hi, I'm Seth, part of Resolve Consulting. Thanks for having us.
Let us know when we should go ahead and start.
You can go ahead and start.
Well, hello, everyone. We are Resolve Consulting, and we were brought on by NC Health to assess if expanding their network into the Inland Empire is beneficial or not. First, we'll start off with a market overview and explain our proposed strategic alignment plan. Next, we'll go into detail about the network and community partners we would like to work with. After that, we'll discuss our strategy, risk analysis, and alternative plan. Lastly, we'll explain our financials and next step. With this plan, we'll reach about 200,000 members in 5 years.
Our mission is to really provide access to care for services with an emphasis on quality and cost reductions. There are specific services like behavioral health needs that are not being adequately met. So we would like to see care integration at an organizational level to address those health disparities.
To provide some information about the demographic characteristic, The Inland Empire is a sprawling 2-county region, which is home to around 4.5 million people. While it only has about 10% of California's total population, it has a higher growing population rate of 5.5 over the past 5 years, compared with 3.2% statewide. Inland Empire also faces a severe physician shortage. The region has only 42 primary care physicians per 100,000 residents, compared with 60 statewide, and it is a lot lower than the recommended supply of 60 to 80 per 100,000 residents. Furthermore, based on our projection, minimum 125 primary and specialty physicians in total will need to be contracted to sufficiently provide access and services for our target population. Besides, Latinx residents in the region have a share that is more than 10% greater than the Latinx share of the statewide population. Lastly, the Medi-Cal program covers 1 in 3 people in the region, so it sustained a higher than average rate for the Medi-Cal coverage. To further the market scan, the Inland Empire is served by 38 hospitals or health systems. As shown in the graph, 12 hospitals are independent, accounting for nearly 30% of all discharges. Besides, the region's largest hospitals and systems include Loma Linda, Kaiser, UHS, and the 2 county hospitals, which are RUHS Medical Center and ARMC. Even though some hospitals are dominant players in their submarkets, we can tell from this graph that the market is very unconsolidated, as no hospital or health system accounts for more than 13% of all discharges.
One of the biggest barriers of moving into the IE is the lack of belief by health management. Getting the facilities to work together and communicate is a challenge, but there are plenty of savings to be made from containing costs of care by standardizing operations. While we're focusing on costs, there is a quality emphasis as well to have the population be healthier, which will theoretically address the risk of patients requiring higher costs of care in the future.
For our strategic alignment plan, we are proposing a Medi-Cal Medicare ACO that consists of 5 components: a health system affiliation between Prime Health and county hospitals for both Riverside and San Bernardino County, developing a health plan by creating a partnership with Inland Empire Health Plan, also known as IEHP, and behavioral health through CalAIM. Working with 4 community organizations in behavioral health and long-term care that are already very involved in the Inland Empire community, incentivizing providers to join our network through a per member per month limited capitation, and using our close relationship with Loma Linda, which is an academic medical center, to use their services to get research and data. NC Health System has expertise with the Medicaid population and programs addressing social determinants of health, which is why we decided to choose this type of ACO for the Inland Empire.
We are referring to our strategy as the Pioneer Program because it will be the first Medicaid Medicare ACO in all of California. We have seen other states do this successfully, such as Oregon and Massachusetts. This, however, is on a statewide level, and our version will be much scaled down. We plan to achieve this by creating key partnerships, then applying for DSRIP funding, expanding into the community, and we really want to emphasize our quality management. We really need to measure to what degree that the Pioneer Program has reduced things like readmission rates, increased drug management, and provided continuity of care.
On the map, you can see that Inland Empire is a large region of land consisting of Riverside and San Bernardino County. And in order to have a network that reaches all parts of this area, we believe that creating a partnership with the following organizations is the best strategy. And we'll go into detail on how this would work.
Our first partner is Prime Healthcare Services. Understood that they are a for-profit company, but they do still have a substantial Medi-Cal Medicare payer mix, so they would be inclined to listen to a proposal of lowering costs. They have 5 hospitals in the area, and we project that by joining our ACO, they can save just under $22 million in 5 years. Their large market share is the biggest reason why. They are so dominant in the area that the opportunity to reach the highest number of patients exists with their involvement. Pairing them with IEHP provides a solid network of payers. In addition, hospitals have a bonus for bringing down the cost of IEHP members. What they would gain from partnering is an expanded network of hospitals, better online and social media presence, which Resolve ACO specializes in, and reduced costs. Managed care plans and shorter lengths of stay can be the future with big player participation like PHS. The second partner is Beaver Medical Group. They are the largest independent medical group in the IE and an attractive option for aspiring physicians that we hope will increase the number of PCPs and specialists in the region. They have excellent quality scores and are the only group in the area to provide a hospitalist, a patient ambassador, for inpatients. They prioritize screenings such as for breast cancer, kidney function, so they are already engaging in care management. What we can offer them are financial incentives. They hold a strong market. So what we want to do is reduce their costs and work on operational efficiency across the ACO. They use Epic EHR, which would make the alignment process smoother. It may be a challenge to get them to join because of their current payment model, but the financial incentives will be the founding argument to bring them aboard, and the community initiatives to help the patient population are relevant as well.
The next partner would be the two county hospitals, which are Arrowhead Regional Medical Center and Riverside University Health System Medical Center. They together play a key safety net role, providing 19% of Medi-Cal discharges with the great extent of primary care and specialty care. Also, Riverside County Hospitals feeds under the broader county umbrella that includes 12 FQHCs, with locations widespread throughout the region. So it will be beneficial to have the county hospitals as our primary care networks. However, facing financial pressures and less available funding, they need to shift away from fee-for-service Medi-Cal payments and require other strategies to serve patients efficiently. Therefore, with the value-based payment offering by the ACO can largely help the county hospitals to reduce costs with 4.5% total savings based on the 5-year projections. ACO will also offer data sharing by Epic EHR, integrated network, and better care management. With all this, the county hospitals would gain benefits of better coordination of care, better patient engagement, and most importantly, it could help them to largely improve quality for their below average quality scores.
As population health continues to be a focus in healthcare, hospitals and other healthcare organizations are taking on more leadership roles in their community. It's really important to foster those cross-collaborative communications. The three main areas that these organizations are targeting are specifically access to care, chronic medical conditions, mental and behavioral health, as well as nutrition. Giving back to the community is essential to addressing some of the social determinants of health in the Inland Empire region, and we are really hoping to collaborate with some of our key partners like IEHP and Beaver on future endeavors.
As mentioned earlier, we plan to reach 200,000 members in 5 years. In order to reach this many enrollees, our network would need to capture 1.5% of the Medicare population and 2% of the Medi-Cal population in the Inland Empire. This is about 10,000 Medicare and 30,000 Medi-Cal patients per year. Through our projection, we will have 207,740 members by 2025. We can reach this many members by creating a marketing strategy tailored to this population in order to capture membership through community outreach, billboards, and social media campaigns.
Here we wanted to outline the amount of risk that is associated with our strategy due to creating the ICO being a high-risk endeavor. Here you can see that the ACO development itself is high risk in terms of operational, financial, and cultural risk. The ACO will have high startup costs, however, it does aim to reduce things like lower ED rates, rates of high-cost imaging, readmission, which all have the potential to result in cost savings and operational efficiencies. The third part of our strategy is EHR integration, which is something we see as being an essential part of the ACO in order to provide continuity of care of those patients. We do believe that this will have a high financial risk, medium operational risk, but low cultural risk. And it should be easier to integrate with our partners because they're all using Epic, so we don't see this being a huge switch over. The third aspect of our strategy is community partnerships. We think community partnerships are one of the most important ways to address social determinants of health outside of the inpatient and outpatient setting. This strategy would be considered to be medium financial risk, low operational risk, and medium cultural risk. Additionally, we did want to provide you with an alternative option that can actually still build up to the ACO structure that we have previously mentioned. This plan utilizes a needs assessment to create a network of FQHC medical homes. Some hospitals have actually found that placing an FQHC near or on their hospital campus ensures that patients are appropriately seen in a primary care setting and not in an emergency room or inpatient setting. FQHCs may not be able to treat all patient levels just due to different levels of acuity. So in that case, we want to work very closely with Loma Linda to refer specialty and outpatients. Health information exchanges are essential to obtaining the data necessary to provide continuity of care as well as measuring quality. Incorporating FQHCs into the ACO will actually bring more access to specialists, ambulatory care, and hospitals to underserved areas, while still increasing the ACO's expertise with high need, high cost patients.
Here are some financials to consider. Our model is based on primary care capitation with an incentive for them to bring down the cost of care. And also for hospital providers, they have a bonus program for the cost reduction. So under our strategic plan, the total savings would be around $110 million based on the 5-year projections. The total earned share savings, which is the bonus revenue, would also be close to $107 million over 5 years. Although the average PMPM for the first 2 years would be around $400, for year 5, it will be adjusted to $187. And as shown in the graph, the 5-year trend for both savings and bonus will be increasing.
Here's an overview of the strategies that we have discussed today. We do anticipate the ACO could have about a 10-year development plan, although we anticipate that success will come much sooner. In 2025, we will reach our target of that 200,000 Medicare and Medicaid members, and we estimated EHR integration to take about 4.5 years, while community partnerships will take about 5. All of these strategies can be adjusted just depending on how far in depth you'd like to go into them.
And that concludes our presentation. So thank you so much for listening, and we'll take any questions you may have.
This is Mark. First of all, I appreciate your confidence. Good presentation. You sound very confident in being able to do this. I'm glad at the very end I heard that this is a 10-year plan, because for the most of your presentation, I was wondering how the heck you're going to pull this off in short order. You have a large coalition that you're talking about putting together. There hasn't been a lot of success in ACOs in California to prove out, proof of concept for the risk that everybody would be taking on. So I think it's conservative that you're talking about getting all of the partners together in a single year to kick this thing off. But I'm glad you said it realistically was a 10-year plan. I have a lot of questions, but I'll keep it to one. What is your plan B? If you can't get everybody together in the first or second year, what's your fallback plan? And I guess a corollary question is, if you have to revert to plan B, how are you going to address the market forces that are likely to change in the intervening time? Thank you.
Thanks for your question, Mark. So the plan B was pretty much what I mentioned as building out the FQHC with a medical home partnership. I do think that that's something that's much more achievable, and it shouldn't have the same type of endeavor. Additionally, for that FQHC expansion, there's certain tax credits that the government can actually contribute more to this type of endeavor due to the Medicare Shared Savings Program. So the FQHC are also allowed to form ACOs. However, if someone could switch to Plan B slide, that would be great. So that would really be our more conservative Plan B, and I think that would still address the needs for specialty care as well. As far as building those partnerships, we do understand that that's something that takes time, but with the support of government funding, I think that would be much more attainable.
So thank you for your presentation. As I was looking at your PMPM's aggressive reduction over a 5-year time. I'm wondering how you're going to, or how did you come to that strategic sort of projection? So you went from $400 per member per month to what, 187, which is pretty aggressive in a 5-year time frame. Wondering if in the analysis of your partners, what was the thought process around cost and how are you going to achieve those cost savings? Just curious as to what your review was and sort of how did you conclude that?
Yes, so our model is for primary care cap with incentive for the cost management, and then the bonus plans for the hospitals and specialists for sharing the savings. So our goal is mainly focused on the cost sharing and save the cost. And for the adjustment from the PMPM from $400 to $187 is because I consider the risk adjustment for 5 years. So I think the risk will be decreasing like after for the first 2 years tryout. So that would be the reason like we adjust the risk after 2 years. And the cost is for 5 years for total partnerships. The total projected savings is for all partnerships.
And question related to that, you mentioned earlier that you are introducing this as an ACO for the Inland Empire as a pioneer program, and you drew inspiration from similar types of programs being done in other states. So to what degree did you draw statistics or data, kind of findings out of their learnings and plug them into your analysis to defend, things like PMPM and various of your other conclusions?
Absolutely. So programs like both the Massachusetts and Oregon that I mentioned, they did have these endeavors. However, they were on a much larger level. Like these were statewide initiatives. So as far as number goes, we had a kind of, I believe Madeline looked at more traditional ACOs, and then we worked in that Medicaid component that wasn't already present in these Medicare ACOs.
Mm-hmm.
I'm not sure if that fully answers your question, but feel free if you need any more explanation.
I'll let some of the other judges pose questions in that we've got limited time. Thank you.
Looks like we just made time, everyone. So thank you so much for your questions.
Okay.
Resolve. Thank you so much. Great job.
Great job. Thank
Good
you.
job.
Thank you.
We'll send the judges now back to their breakout rooms. Resolve, you can take a deep breath, and we will bring in the next team.